The test item cluster for a patient that would benefit from thoracic manipulation who has mechanical neck pain would be a less than 30 days onset, no symptoms distal to the shoulder, a diminished thoracic kyphosis in the spine, a less than a 12 on their fear avoidance questionnaire, a less than a 30-degree in cervical extension measured with the goniometer, and looking up does not aggravate their symptoms. So I will now demonstrate the extension. Could I have you please look up? Thank you. The test item cluster for a patient with a full thickness rotator cuff tear versus a patient with subacromial impingement syndrome would both include a painful arc and a positive infraspinatus test, which I will now demonstrate. Could I have you raise your arms and come back down? Hold your arms at 90 degrees and 90 degrees. I'm looking for an inferior drift of the arm or pain reproduced to be a positive infraspinatus test with a painful arc. I'm looking for a pain through the motion. Positive drop arm test would be when my patient raises her arms, come up and down. She would have poor eccentric control of her arms. Then the subacromial impingement syndrome, instead of a drop arm, would include a Hawkins-Kennedy test, which I will now demonstrate. Could I have you go like this, please, with your arm? Thank you. I will apply a medial pressure, and I'm looking for reproduction of her symptoms or pain in my patient. The test item cluster for a patient who would benefit from cervical manipulation with mechanical neck pain, the patient would have a positive perspective on cervical manipulation. It would be a less than a 38-day onset for the patient, so it's still acute. They would have a greater difference in bilateral rotation of the head of 10 degrees, and they would have painful or hypomobile PA mobes, which are applied to the cervical spine. The test item cluster for a patient with cervical radiculopathy would be restricted rotation ipsilaterally, less than 60 degrees, so I'll have my patient look left, have my patient look right. They would have a positive Sperling's test, which can be demonstrated as follows. I will apply overpressure. If there is no pain, I will have them look up and apply overpressure. If no pain, I will have them look up and rotate their head, and I will apply pressure. Then, if neither of those reproduce their symptoms, I will then apply a cervical distraction test and raise up on their head, looking for alleviation of their symptoms. The final thing is an upper limb tension test, which is measured, and you're looking for three things: reproduction of their symptoms, a greater than 10 degrees of elbow extension, which I will show you, sensitization of symptoms with lateral side bend to the opposite side. Have my patient lay down, please. I will take them in the shoulder abduction, block with my hand here, external rotation, supination at the forearm, extension of the wrist and fingers, and I'm looking for a greater than 10 degrees of extension in elbow extension bilaterally. Test item cluster for the upper limb tension test of my choice will be the upper limb neural tension test measured with shoulder abduction, external rotation, supination, wrist extension, and wrist and finger extension, looking for a greater than 10 degrees of extension bilaterally, sensitization of their symptoms with lateral side bending, or reproduction of their symptoms in general. I will block their arm here, shoulder abduction. I will take them into supination, finger extension, wrist extension, and then elbow extension, looking for a greater than 10 degrees. I would test that bilaterally. I will now perform an active compression test of O'Brien. I will have my patient put her arm in 90 degrees of shoulder flexion, thumb facing down, and I'm going to be applying a medial and downward rotation. Hold here for 5 seconds. If this provokes the patient's symptoms or produces pain, it could indicate a slap involvement or biceps brachii involvement. I will now perform a load and shift test of the glenohumeral joint. If the test is positive, the posterior capsule will restrict posterior translation and the anterior capsule will be excessive or painful. You have the patient sit in neutral position here. You apply a medial force and you move posteriorly or you move anteriorly. If there's excessive translation or pain, your patient has a positive. The apprehension or crank test of the anterior shoulder is used to check for if someone has a loose anterior capsule or if they have an unstable shoulder. How you perform this is you place them in external rotation, arm abducted at 90 degrees, and you apply an external rotation force. You have a downward force on your opposite hand over the anterior capsule. As you release, if there's a pain or if the patient is apprehensive about the test, then it is considered a positive. I will now perform the supraspinatus or empty can or Job test. If a patient has a torn or partially torn or an involved supraspinatus injury, this test will provoke those symptoms. So first, the patient will place her arm 90 degrees of abduction, thumb facing up for maximal supraspinatus contraction. If this is painful, the patient will turn their thumb down. You apply a 5-second hold, stabilizing proximally. Then once you've completed that, you move into 30 degrees of horizontal abduction, still arm abducted, apply a pressure. If this is too painful, then you will place the thumb down for maximal supraspinatus contraction. I will now differentiate between a C5 and C6 radiculopathy versus a rotator cuff tear or rotator cuff impingement. If someone has a rotator cuff tear or rotator cuff impingement, you would look for a positive in the test item cluster. If it's a full thickness or partial thickness tear of the rotator cuff, you would most likely see more positive tests. However, if you have a C5 or C6 radiculopathy, you're more likely to see numbness, tingling. You will see very similar symptoms of people waking up in the middle of the night. However, you would have arm going numb, you might have arterial involvement, but you would have diffuse weakness in a radicular lesion, and you would have isolated weakness if you would have a rotator cuff tear or impingement. Muscles that would be weak would be subclavius, supraspinatus, infraspinatus, biceps brachii, deltoid, teres major, teres minor, brachioradialis, subscapularis, pectoralis major, coracobrachialis, serratus anterior, supinator, extensor carpi radialis brevis, extensor carpi radialis longus, as well as the latissimus dorsi, potentially other muscles that have C5 or C6 involvement. Taking a good history is the best way to get to the bottom line of what would lead your special test to be more clinically applicable.